According to International Diabetic Federation, 3 years back there were more than 8 crore people suffering from diabetes in India. Unfortunately, this population is going to increase tremendously in coming 25 years, and India will probably the capital of diabetes, which is an alarming situation. And this population will almost double to more than 15 crore individuals suffering from diabetes alone in India, only next to African population. Unfortunately, about two-thirds of diabetic patients are still uncontrolled despite receiving treatment. This is something which is quite alarming for us. We know that diabetes is a complex disease with chronic hyperglycemia, which causes gradually increasing over time. It leads to so many metabolic disorders in the body, including abdominal obesity, dyslipidemia, atherogenic conditions, non-alcoholic hepatitis, and this is being supported by Framingham Offspring study, which shows that two-thirds of diabetic patients have subclinical cardiovascular disorders. This condition is almost 4 times the normal population in the diabetic population and is a major cause for premature death in diabetics. Almost 70 to 75%, three-fourths of the death in diabetic population is due to the cardiovascular complications. Atherosclerotic cardiovascular disease occurs almost 15 years earlier in diabetes when compared to normal population, and the risk of heart failure is almost 2 to 5 times higher in diabetic population. So we see that diabetic is not only a blood increase in blood sugar, but it comes as a package with so many complications attached to it. Failure is second commonest cause of diabetic cardiomyopathy, and it may present quite early in presence of diabetes. We have seen that the prevalence of diabetes is increasing day by day, and it is not just diabetes, it is also associated with so many complications, and these complications tend to increase with poor control of diabetes, and we South Indian phenotype are unnecessarily genetically predisposed to early macro and microvascular complications of diabetes, and that means it adds to high cost of treating not only diabetes but also the complications. So if we want to get rid of all these complications so as to prevent the various diabetic complications and reduce the cost of therapy, for that, what we need to do is we need to start multiple drugs initially in the treatment so as to take care of the various pathophysiologic process associated with diabetes, and earlier the multiple used, better is the result. This graph clearly shows that use of single drug, that is monotherapy, for a long duration of time leads to a lot of glycemic complications without achieving the glycemic goals. But if we are able to add more than one treatment, we are able to achieve the glycemic goal of HbA1c of less, which is sustained effect, and hence the complications of the diabetes also tends to reduce. Now, coming to the rationale of combination of these two drugs, the SGLT2 inhibitors and DPP4 inhibitors. These are two class of drugs which we are now being used in management of diabetes. In healthy individuals, SGLT2 receptors, the sodium glucose transport 2 receptors, which are present in the proximal part of the convoluted tubule of the nephron, mediates the 80 to 90% of renal glucose reabsorption. This is a normal physiology. Now, this particular medicine, the SGLT2 inhibitor, which is the latest in its class, tends to reduce the renal glucose reabsorption by almost 50% by promoting the glucose excretion through the nephrons, and this action is insulin independent. It is having this effect without the presence or absence of insulin in the body, and also it is independent of the pancreatic beta cell function and the insulin sensitivity. This is a molecule which can be combined with other oral hypoglycemic agents as well, including insulin. Now, the other class of drug, the DPP-4 inhibitor, tends to increase the half-life of intestinal-derived incretin hormone, GIP-1 and GLP-1, and it also causes insulin secretion from pancreatic beta cells, which is glucose dependent, food dependent. That means unless and until we intake food, this pancreatic beta cell will not secrete insulin. So it is mimicking the normal physiology of the body. It also causes decreased glucose levels in an insulin dependent manner. So, and it also causes decreased glucagon, which is normal physiology. So there are multiple actions of this particular molecule which helps in reducing the hyperglycemic state. It also inhibits the endogenous glucose production from the liver. So these two drugs put together tends to improve the beta cell function as well as insulin sensitivity. We see this in a tabular form where DPP-4 inhibitor has a glucose dependent insulin secretion and inhibits glucagon secretion. On the other hand, SGLT2 inhibitor promotes glucagon secretion. Therefore, these two drugs tend to have synergistic effect. Therefore, it will not cause hypoglycemia. Also, SGLT2 inhibitors causes glucosuria and it increases beta cell sensitivity by reducing the glucotoxicity, which is being which action is present also with DPP-4 inhibitor. Also, DPP-4 inhibitor causes inhibition of degradation of incretin, that is GLP-1. So these are the multiple factors, the various factors of forminus actate on which these two drugs put together act to manage the hyperglycemic state of the patient. We see this in a graphical form, how DPP-4 inhibitor not only has an incretin effect, but also it's weight neutral and has pleiotropic effect along with reducing the hyperglycemic state. Similarly, SGLT2 inhibitors along with glucosuria causes systolic and diastolic blood pressure. All these put together tend to maintain the euglycemic state and increases the insulin and beta cell sensitivity. This in maintaining the fasting as well as postprandial blood glucose levels and therefore also reduction in HbA1c levels. So these two drugs put together have minimum risk of hypoglycemia, which may be there if we are using these drugs alone. There has been so many studies in last 8 to 10 years with these two class of drugs, the SGLT2 inhibitors and the DPP-4 inhibitors. Today we are going the EMPA-REG study in particular along with the Carolina and Carmelina study of Linagliptin, which have shown superiority in various manner. See these in coming slides. We have SGLT2 inhibitors decrease renal glucose reabsorption by regulating the renal function and inhibiting this particular receptor in proximal convoluted tubule, which causes glucosuria and natriuresis, which leads to not only reduction in blood glucose level, but also an reduction in systolic and diastolic blood pressure. Not only this, the ADA latest guidelines 2020 also suggests that the first line management in management of diabetes in presence of atherosclerotic cardiovascular disease, established CKD and heart failure, along with metformin lifestyle modification amongst the oral hypoglycemic agents is SGLT2 inhibitors followed by DPP-4 inhibitors. When CKD is there or hypoglycemia is a main concern, once again in hypoglycemic to prevent hypoglycemia and maintaining euglycemic condition, a combination of DPP-4 and SGLT2 is a preferred choice so as we do not have side effects and we are able to maintain the euglycemic state when we are talking about oral hypoglycemic agents. This holds true also for patients in which weight loss is an important aspect. So we see that in patients with established atherosclerotic diseases, CKD, or heart failure, when we talk about oral hypoglycemic agents, it is the SGLT2 inhibitors and DPP-4 inhibitor combination which is being preferred also by ADA. This holds true even for European guidelines, where they go a step ahead that if there is a drug naive patient, that is, a new patient is being managed for diabetes in presence of cardiovascular disease, it is the combination of SGLT2 inhibitors followed by metformin and DPP-4 inhibitor which should be preferred rather than starting with metformin monotherapy alone in drug naive patients in oral hypoglycemic agent class, or those patients who are already on metformin, it is the SGLT2 inhibitors followed by DPP-4 inhibitors in presence of CVD, which should be preferred if HbA1c is not under control. We are unable to achieve the target. We should go with these two molecules when oral hypoglycemic agents. In injectables, GLP-1 receptor agonist is a choice, but cost becomes a big factor, and we in India find a great concern among patients about using injectables in management of diabetes. The statement from the assessment of CVD in type 2 diabetes in presence of atherosclerotic disease, CKD, and heart failure has shown that a combination of SGLT2 followed by DPP-4 is preferred choice, and previously used sulfonylurea has gone down the list a lot. When we talk about heart failure and CKD patients, TZD, that is thiazolidinedione, should be avoided and should not be used probably because of the risk of fluid retention which can worsen the heart failure, and therefore this should not be used. So a combination of SGL2 and DPP4 is a preferred choice in ASCVD, CKD, and heart failure patients with both these important bodies, that is ADA and European Association on management of diabetes. The CVOTs from SGLT2 inhibitors in last 5 years have talked about 4 different molecules: the EMPA, the CANA, DAPA, and Empagliflozin. We see that there are large studies with these molecules, but the number of 3P MACE events which has occurred with come to the tools. Percentage is encompassed amongst SGLT2 inhibitor. EMPA again becomes a preferred choice. As we see further, this was a study on more than 7,000 patients with age group of average 63, A1C of 8.1, with diabetic nephropathy in 11% patient, with average blood pressure of 135 by 77, and almost 80% of patients were classified in 3 groups, randomized to EMPA 25, EMPA 10, and placebo, and studied for 3 years. They showed there was 14% reduction, relative risk reduction in primary outcome, which was a composite of CV death, non-fatal MI, and non-fatal stroke. The CV death reduced by almost 38% and the total mortality reduced by 32%. So that's a significant information which we have seen in empiric outcome with an HbA1c reduction of almost 0.5 to 6% and systolic blood pressure reduced by almost 5 millimeters of mercury. So these are the various benefits which we have seen along with reduction of hospitalization for heart failure, with reduction of by 35% and almost 40% reduction in new onset or cases which we are seeing with these outcomes were noted as early as 3 months, and these effects were probably because of the various factors, including reduction in preload and afterload over the heart, the changing in energetics metabolism of free fatty acids, the cause they were ejaculation. So these were the various factors which these benefits. When we compare Empiric with Canvas program and Declare TB, we see maximally beneficial in terms of whereas it was least with DAPA, most beneficial with Empa by relative. If we talk of 3P MACE, we have similar data in terms of and renal outcomes are similar in all the three molecules. We do not have any CWAT for Empa that all we have beneficial results with Empa in comparison to the other SGLT2 inhibitors. And these benefits glycemic control, that is, despite HbA1c being less than 7 or more than 9, in all the situations, we see that this benefit of CV outcome is present with Empa when compared to placebo. So this CVOT benefit is beneficial in when independent of the HbA1c levels. The AAC guidelines also suggest that if we are unable to achieve a glycemic control, we should use SGLT2 inhibitors in initial management of therapy, even as monotherapy. When come to dual therapy or triple therapy, also a combination of SGLT2, DPP4, and metformin among oral drugs. And if we are going for injectables, GLP-1 receptor agonist can be used, followed by insulin. So the consensus for management of diabetes has changed, and recent guidelines are promoting these molecules. The benefit of SGLT2 inhibitors have been seen also on heart failure, where natriuresis tends to cause reduction in intracellular sodium load and changes cardiac substrate utilization, probably by ketone body superfuel hypothesis, and which has been further established in Emperor Reduce, where the benefit is not only limited to diabetic heart failure patients but also to non-diabetic individuals suffering from heart failure. The hospitalization for heart failure with uses of EMPA has reduced by 35%, and this benefit has been seen to be sustained over a period of 4 years. So we see that hospitalization for heart failure in SGLT2 inhibitors has shown benefit not only with EMPA but also with other molecules. But when we see that this benefit is maximum with EMPA of around about 35%, and on an average with primary secondary all there is 27% reduction in hospitalization for heart failure. So we can say that there is a class effect in terms of hospitalization for heart failure with maximum benefit with EMPA findings. Coming to the renal outcomes, the microvascular complications, including as secondary outcome, and renal outcomes were defined as composite of initiation of retinal photocoagulation or vitreous hemorrhage or diabetes related blindness or worsening nephropathy, which was defined as progression of macroalbuminuria, doubling of serum creatinine with EGFR of less than 45, or initiation of renal replacement therapy or death due to renal disease. So these four criteria were defined as nephropathy, and others were defined as retinopathy, which were the secondary microvascular complications in Empiric renal trial. It was compared with credence, where COX regression was used, which included end-stage renal disease, initiation of renal replacement therapy, sustained eGFR of less than 15, doubling of creatinine, or renal cardiovascular death. The secondary outcomes which were included renal outcome which we defined just now with hospitalization of heart failure, severe death, ARF, and hyperkalemia. In credence, EGFR taken was between 30 and 90 with urinary average more than 300, and non-credence group where EGFR more than 90 and album creatinine ratio less than 300. So when EMPA data was compared in this fashion of dividing the patients into two parts, the credence like, that is those patients who fitted in credence criteria, and those who did not fit in credence criteria, that is non-credence group. Now they were compared, and it was found that the results with EMPA was similar to credence. EMPA and CANA showed similar results in renal composite outcome in terms of proteinuria, cardiac outcomes, and this effect was sustained not only to end-stage renal disease but also to hospitalization for heart failure, which we have seen earlier also, along with severe death and overall mortality also. So this particular slide shows that the benefit which we have seen in credence is only to CANA, but it is also being seen in EMPA. So this is a class effect, and EMPA this way is scoring because it has CV benefit much more, which is not there with other molecules. So this is an added advantage of EMPA in comparison to other molecules. So we have seen that SGLT2 working on kidney causes glucosuria, leading on to reduce fasting and PPG levels by reduction of HbA1c almost 1%, with weight loss of 2 to 3 kgs, increased sodium excretion, leading to reduced sodium load and blood pressure of almost 3 to 5 millimeters of mercury. Sorry. Coming to DPP-4 inhibitors, four molecules being compared: Saxa, Teni, Sita, and Lina. All can be used as mono, dual, and triple therapy. They are quite compliant with all the molecules, including insulin. Now, coming to the safety profile, are CV safe other than Teneli, where there is risk of QT prolongation, specifically when used in heart failure. Saxa tends to increase the chances of heart failure. We do not have sufficient data with Teneli and Teneli for heart failure and renal involvement. Sita is safe in terms of heart failure, but Lina is safe in all the three situations of CV risk, the heart failure, as well as renal involvement. So once again, we see that amongst these four molecules, Lina is most safe in all the mentioned in presence of hospital for heart failure and diabetes, along with DPP-4 inhibitor, where it prefers Sita and Lina in management of here also these two molecules have shown to be neutral effect on left interaction. Combination of SGLT2 inhibitors and DPP-4 with Lina is a preferred choice in management of cardiovascular disease in presence of diabetes. The Carmelina showed there was 14% reduction in progression of albuminuria and more than 50% reduction in albumin creatinine ratio. So once data is such which shows benefit in terms of renal involvement with linagliptin in Carmelina study. The findings from Carmelina showing that these are long CV which has been provided not any other molecule showed to be beneficial in terms of increasing the heart failure. One, second, this has comparison to sulfonylurea that glimepiride. Third point, it has lower risk of hypoglycemia in comparison glimepiride and associated with reduction in comparison to glimepiride. So we see that these two, Carmelina and Carolina, have CV outcomes with real profile when compared to other molecules in a large number of patients. Now, coming to this combination of SGLT2 inhibitor along with 4 inhibitor in shown to be superior in terms of 3-point cardiovascular events, the CV death, hospitalization for heart failure, and renal outcomes. And Lina is neutral in all these situations. When we compare this thing with DEPA and SEXA combination, we see that DEPA has only beneficial data in hospitalization for heart failure and renal outcomes, whereas SEXA combination tends to increase, and we do not have much of data on renal profile. Erthogliptin in itself, data is not yet available, and CETA is in combination what to talk since Ertho has insufficient data as of now. Slide once again emphasizes that when we go for a combination SGLT2 and DPP4, as of now, EMPA and Lina is most safe, not only in terms of cardiovascular outcomes but also in renal outcomes. If we talk about reduction in HbA1c level, we also see that this combination tends to HbA1c level by more than 1%, not only in patient but also in those patients who have been on metformin since long. This combination has taken care of hyperglycemia in various manners when put together by inhibiting the glucose muscle causing glycosuria, which is dependent on the glucose levels by absorption of the fluid, absorption of the food. It takes care of the GLP-1, the incretin effect. The glucagon secretion is being inhibited by DP4. So all these put together tends to take care of the ominous lactate, which is an important criteria in management of diabetes. Also, it has been shown that chances of achieving the goal HbA1c is almost twice to 4 times higher when compared to monotherapy in the background. That is, those patients who are put either on Lina or EMPA individually, and when this data is being compared with combination of EMPA and Lina, either 25 or 10 milligram, we see that chances of achieving HbA1c is almost twice to thrice in combination group. So this benefit is another thing there. There is reduction of 2 to 3 kgs of body weight, 2 to 5 millimeters of mercury reduction in systolic and diastolic blood pressure. So these are the added benefits of using this particular molecule combination. There is no risk of hypoglycemia for that matter. When combination of these two drugs are used, the risk of hypoglycemia is lesser in comparison to using single drug, that is EMPA or Lina, probably because of the synergistic effect which happens. One is causing inhibition of glucagon, another is causing promotion of glucagon. So body tends to take care of these particular things, and therefore hypoglycemia is being prevented. uh, Coming to the urinary tract infection, it has also been seen that combination of DPP4 and SGLT2 inhibitors has lesser incidence of genitourinary tract infection, probably because of inhibition of DPP4 enzymes, which is being present in bacteria and fungi. So this particular enzyme is being inhibited in bacteria and fungi, which tend to cause genitourinary tract infection. So this is another benefit. It has also been seen that when sequential addition of SGLT2 was done to DPP4, the chances of infection was higher, and when compared this to simultaneous addition of SGLT2 and DPP4 in management of diabetes, the relative risk was much lesser, almost one third. and probably equal to the placebo. So this is how the reduction in genital infection is a significant finding in combination of these two drugs. So to conclude, I could say that EMPA and Lina fixed dose combination has a robust data in terms of reduction of HbA1c, fasting PPG levels, and 2 to 4 times higher chances of achieving the goal with a durable effect with early achievement of HbA1c goal. These molecules need not escalate their doses when put together in management of diabetes. They have shown to be proven CV, cardiovascular, and heart failure evidence. With renal evidence is also in favor of these two molecules. Quite safe, tends to reduce albuminuria, urinary albumin creatinine ratios, reduction in hospitalization for heart failure, 3 point measure adverse. All these are quite beneficial, along with weight loss, reduction in urinary tract infection, and convenience once daily dosing. With that, I would like to conclude my talk. Thank you so much. If you have any questions, you are most welcome.
Sir, there are one question in
There's
chat
a question.
box.
If a patient is not controlled on conventional therapy, required to add insulin, rather than adding insulin, can I add Empagliflozin combination? Can this combination delay insulin initiation? How much year it delay insulin initiation or pick phobia patients? See, that's a wonderful thing. Definitely, a patient who is not controlled on conventional therapy is a good candidate for Empagliflozin. And we should also remember it is not only that Empagliflozin is going to control his blood sugar, but also is going to postpone the complications associated with that is one. The initiation of insulin will also be postponed when we are using this combination. Why is this happening? Because these two molecules do not act directly on beta cells, so they are actually preserving the beta cell. One. Second, it causes glucosuria, that is excreting the glucose through the urinary tract. So this way it is reducing the load of blood glucose in the body. So this way it is helping in management of diabetes. And when these two put together, there is also minimum risk of hypoglycemia because of probably the glucagon effect, also the GLP-1, the incretin effect. These two put together tend to help a lot in management of diabetes of this particular patient. And you are very right in saying that insulin initiation will be postponed with this combination. Any other question?
So there are no further questions. So can we wait for a couple of minutes?
Sure.
So there are no further questions. So can we wait or can we conclude this session?
As you say, if you wish, we can conclude the session. If you wish, I will wait. I have no issues with that.
Okay, sir.
In the
So
meantime, I would
wait
like to
for
just
another
add
one.
one more point. It is a good idea to have a good amount of water intake with this particular. Yes, there is a one question. One question here: can we give this to liver cirrhosis patient? That's a very good question. metabolism of linagliptin is through renal pathway. So no issues. On once again the renal pathway, it is acting on SGLT2 inhibitors, which is in proximal coronary tubule. So these two are quite safe in renal patients also. Hepatic patients also. Of course, there are so many things. Of course, so there are so many things which are associated in diabetes. There are multiple things, multiple organ involvement. So we should keep a tab on the to check if there is any worsening. But as such, these are safe molecules in liver cirrhosis patients. No issues.
So, sir, with your permission, shall we conclude the session?
Okay, thank you so much.
Okay, sir. So, on behalf of organizer, I would like to thank you for your insightful and educated talk. Thank you, sir.
Thank you so much. Thank you so much, Lupin, for arranging the talk.